Good morning. Today I am presenting on behalf of Medicine 4. My topic is the passage. So I'll be presenting two case reports. For case 1, so Mrs. X, 55-year-old lady from Gudiyatham, Vellore. She presented with right-sided facial pain for 2 weeks and associated facial swelling for 10 days and discoloration over the right half of the nose for 3 days and history of fever for 3 days. Prior to these complaints, 3 weeks ago, she underwent right lower tooth extraction for dental caries, and 5 days after that, the started developing the facial pain and swelling. So, past history wise, is a known prior comorbidities. Examination wise, vitals are stable. And evaluation GRBS was very high with serum ketones of 5.3. And local examination is swelling over the right half of the face with blackish discoloration over the right half of nose is seen. Mass in the right nasal cavity with blood stains are present, and the right periorbital edema were present. System examination wise, right-sided ptosis was present. Right pupil reacting to light and counting fingers with a frozen globe. Left pupils are normal. Otherwise, higher mental functions and all other CNS systems are normal. So the differentials we considered were rhino-orbital mucormycosis, acute bacterial rhinosinusitis, or orbital pseudotumors, and cavernous sinus thrombosis. So her initial investigation showed a HbA1c of 13.6, suggestive of uncontrolled diabetes, and the total counts are elevated. Her culture fungus from the hard palate showed a rhizopus arizus, which is suggestive of a mucormycosis, and the biopsy also showed a evidence of angioinvasion of the mucormycosis. So MRCT base of skull was done, which also features suggestive of invasive fungal sinusitis with transfacial spread. So we came to a diagnosis of invasive sino-rhino-orbital mucormycosis with uncontrolled due to risk factors of uncontrolled diabetes mellitus. So second case is a Mr. A, 56-year-old gentleman from Gudiyatham, Vellore. He presented with diplopia of right eye for 1 week, right-sided nasal obstruction stuffiness with decreased smell sensations present. Before this history started, only underwent right upper second premolar extraction on 21st for the toothache, following which the headache worsened and the diplopia started, following which the other complaints started. He is also known diabetic for past 4 years on irregular medications. So, examination wise, local examination purulent nasal discharge were present in the bilateral nasal cavity, and CNS wise, right eye incomplete ptosis of the right eye, a reduced height of the palpebral fissure is seen, a restricted abduction, adduction, and supra-adduction is limited, and V1, V2 sensations were intact. The deviation of angle of mouth to the right side was present. So, a gag is present, and otherwise, ankle jerk is alone absent. Other CNS examinations were remarkable. So again, the differentials considered were acute bacterial sinusitis, a mucociliary abscess, a mucormycosis, or could be a neoplasm later, petioadenoma meningiomas. The others are orbital pseudotumor, Toscan syndrome. His investigations also showed a total counts of elevated with HbA1c of 12.7, suggestion of uncontrolled sugars. Initially, ENT was seen in the ED. On evaluation, bilateral nasal discharge was present. Bacterial fungal culture from the nasal cavity was sent, which showed no growth. And MRI and CT skull base was done, which was discussed, which suggested a splenoid sinusitis present, features suggestive of more of a bacterial sinusitis than a fungal. So, patient was started on antibiotics. So, in spite of the antibiotics, patient condition was worsening and he was having persistent fever spikes. And hence, he was planned for a phase, which was done on 31/7. And the biopsy from the sphenoid sinuses in the face showed a growth of rhizopus arizus. So, again, this patient is a diagnosis of invasive sinonasal mucormycosis, cavernous sinus involvement with uncontrolled diabetes mellitus was made. So, summarizing, both the cases, the case of uncontrolled diabetes risk factors who underwent prior to the development of a mucormycosis had a history of tooth extraction followed by mucormycosis. So today I'm going to a little bit talk about the mucormycosis following tooth extraction. So in mucormycosis infections, approximately 50% of cases with diabetes are predisposed. This is mainly due to the greater level of glucose, lower pH, and persistent reduction of lead-4, and the subsequent decreased serum immunity, which leads to the mucormycosis. Though the instance of mucormycosis following a tooth extraction is extremely low, it may cause a significant morbidity and mortality. So the exact pathogenesis mechanism of how tooth extraction can lead to mucormycosis is not clearly explained. So it may act as a source of entry of wound by rupturing or breaking the oral mucosal membrane while during the extraction procedures. So in a immunocompromised host, where the germination can occur and it may invade the blood cells. So this is a case report of in Chennai, one of the dental colleges in Chennai, mucormycosis following tooth extraction diabetic patients. So it's a 55-year-old male. He presented pain and sinusitis in left alveolus after maxillary tooth extraction 3 weeks ago. So he had a facial cellulitis left buccal, maxillary and infraorbital areas, difficulty in opening mouth due to the pain, and foul-smelling black discolorations and left mucosal nephrosis. He also has a history of uncontrolled non-insulin dependent diabetes mellitus. Biopsy revealed features suggestive of mucormycosis. So another case report, fulminant mucormycosis of maxillary sinuses after the extraction in patients with uncontrolled diabetes. The 2 case reports are also done. And there is a systematic review where the occurrence of mucormycosis was, the case series was taken and it was systematic review was done. In this systematic review, 31 case reports and 1 case series. Total of 38 cases were taken. The majority cases were from India. Around 50% of the cases were from India. And among them, the male predominance, around 68% were in the male people. The most common site is the maxilla, was the more commonly involved mucormycosis involved more commonly in the maxilla. The risk factors are around 55% of the patients pre-existing diabetes is the risk factors. And the onset period is between 30 days. It can range from 2 weeks to 75 days post the tooth extraction. And in 21% of cases, often is associated with cerebral involvement, which is often associated with diabetes mellitus. So our patients, patient 1 when underwent a bilateral sinonasal debridement plus right subtotal maxillectomy plus right pre-maxillary clearance under GA. The patient doesn't have a cranial involvement. So she was given 2 weeks of conventional amphotericin B and she completed the course. The case 2, he underwent bilateral phase under GA on 31st, currently on conventional amphotericin B. So the learning point is importance of diabetes control before any invasive procedures. The possibilities of mucormycosis after tooth extraction should be considered and create more awareness among the dental practitioners. Small procedure can become life-threatening to the patient. Thank you.
Thank you for a nice presentation, Rajesh. So I think our dental surgeon colleagues are justified in sending them to
Not ours.
sending them cases to us for sure.
Another interesting fact is that both these patients I noticed while preparing this, both are from Gudiyatham and both are from Vellore. Gudiyatham, exactly, both the patients are from Gudiyatham. It's between a 1 month gap, 2 cases we had. The first patient came on 10/6. The second patient is on 28/7.
So this is since you've done the reading, other procedures also, do they have the same risk, or is it only like something as bad as deeply they take out?
More the deeper is that because of the mucosal injury, however much like
with like skin biopsies, excision?
No, sir. I didn't per se look into the other causes per such, but when I try to look into what is the reason for it, the most commonly they're saying is that by tooth extraction, the more the mucosal damage we are causing, the more the chances of it.
Thank you. Any questions from the house here or online?
Is it the same dentist?
That's what I have to go back and maybe find it.
But this is ubiquitous, no? So everywhere these spores are there. Thank you then.
Thanks.